to the trauma bypass for Southern IRHA care map update. So with this actual care map here, there's not a lot of differences to what we're currently doing. There's only a few minor changes, but they are noticeable enough that I've created a short video so we can review the new updates coming out June 1st. So the actual care map itself, the layout hasn't drastically changed, but as of June 1st, the people who were contacting in regards to enacting trauma bypass is going to be different. So on our end, it's not going to change greatly. It's more so on the MTCC side, where they're going to put us in contact with different physicians as opposed to what we're currently doing now. So reasons to use this care map, again, hasn't really changed. So any major trauma where the incident has occurred within the geographic boundaries of the IRHA or Southern Health. So even if we do end up going into different zones, so I know Southern comes into our zone, we tend to go into Southern, we can still enact this same care map regardless of which zone we're in. So there's really no contraindications to using this care map. Obviously, if you don't have a trauma patient, you're not going to use it. Otherwise, it is always consideration with every trauma patient. So with this here, so the first step of trauma bypass is to deal with any life-threatening issues, such as you can't open the airway or the airway can't be maintained, your trauma, their jaws clenched, things like that, actual facial trauma. The patient cannot be ventilated or oxygenated. Same thing. You can't open their mouth. You can't get an airway in. You're having like bleeding in the airway. That's uncontrollable, which goes into uncontrollable exsanguinating hemorrhage as well. So whether it's to do with the airway or not, if they have bleeding and you're using tourniquets, you're using TXA, and you just can't get that bleeding under control, or if you have a suspected tension pneumothorax of your patient, so they're having severe shortness of breath, jugular vein distension, decreased air entry on one side, unilateral chest rise, like those are all things that are very, very concerning. So with those, we're going to transport towards the closest ED because those need to be dealt with immediately. We can't, it's nice if we can go to HSC to deal with those. That's ideally where we want to go. But if you're a fair distance away or there's a hospital like right next door to where you are where this happened, we need to go there first to stabilize that patient. So in regards to what we consider a closest ED, it'll be considered the closest if it has the shortest estimated transport time for the patient's conditions. So again, if you're 2 minutes away from a local hospital, you're like, I know this patient needs to go to HSC, but I can't control his airway, it's full of blood. Go to the closest hospital, get that under control. There's nothing stopping us from going there and getting help and then transferring out. When it comes to closest destinations as well, if two destinations have similar transport times, you transport to the facility with the shortest distance. So it's going to take you 20 minutes to go to this hospital, 20 minutes to go to this hospital, but you can get to one's a little bit closer. You can take that in consideration. If they have similar transport times and distances, so let's say it's going to take you 40 minutes to get to this hospital, 40 minutes to get to that hospital, and you're pretty sure that this patient's going to end up going to HSC, go to the ED closest to the referral center. So obviously, if your options are to go further north or south towards the city, go south. That just makes more sense because they're going to be sent out anyways, so get them close to the hospital you want them to be at. If you're not sure which is the best destination for you, you can always contact MTCC and they'll put you in touch with the transport physicians, or they'll just give you recommendations of which hospitals are available. As everybody's aware, it's more so sometimes just which hospital is open for you. So if a hospital is on a redirect, you can go to the closest hospital, even if they're on redirection, just to get some extra help or work in a stable environment. So because being by yourself in the back of a moving vehicle may not be the best place to deal with someone that's bleeding out, airway issues, all of the above, needs multiple issues dealt with at the same time, we can at least go to the closest facility and get some extra hands, not be in a moving environment. Even if it's just so our partner can help us out to deal with things, it's just a better environment to give care. Again, when we go to a hospital that's on bypass, though, we're not going there to stay, or we're not going to offload. We're going there to get help. We're going to make some phone calls when we get there. We're going to hopefully get the hospital staff to help us out as well to help stabilize our patients so we carry on down the highway. So with that as well, when it comes to going to a hospital that is on bypass, if they are not receptive to you going there, we could always contact online medical. And the online medical physician can actually give the nurses of the facilities orders over the phone. That's a conversation they can have, and that's another resource we have as well. So we can override those diversions just to get help stabilize our patient. But again, this is with the understanding that we're not going to stay there. We're just there to stabilize patient, whether that means we're waiting for the STARS helicopter to show up, or we're just going to spend 20, 30 minutes there getting everything under control that we can't do on our own in the back of a moving vehicle, and then head on down the highway. So it says here as well to call dispatch for trauma bypass as soon as possible. So this is the new addition to the care map. It'll get a little bit more into how it works, but we're no longer going to call for like for stars, things like that. We're just going to call MTCC and say trauma bypass as soon as we can. And again, this is something we can do if we do go to close a CD that's on bypass. Once we're there, we have some hands to help us. We can make that phone call for trauma bypass so we can carry on down the road. So if they don't have an immediate threat to life that we need help immediately, we've got a little bit of time where we can control this right now. We're going to look at table A. So does patient have any of the indications for trauma bypass listed in table A? And this table hasn't changed since we first came out with this care map. So for this one, it's patients who have any of the anatomical, physiological indicators requiring assessment by the Provincial Trauma Service at Health Science Center. So this is part of the new thing with calling for trauma bypass through MTCC is we're more so trying to activate the trauma team or get the trauma team at HSC involved sooner. So if the patient presents with severe penetrating injuries, stab wounds, abdomen, groin stabs, basically stabbed anywhere, it's all bad. Severe blunt injuries to the chest, pelvis, head, spine, or extremities. Again, I'm sure you can determine what is really bad. So if they're crushed, mangled, open book fracture, multiple fractures, long bone fractures, things like that, we can look at calling for bypass. Major burns, especially to the airway, joints, electrical burns, like high electrical burns, those are always consideration. And if the patient's pregnant, so once they're more than 20 weeks gestation, they automatically meet criteria for trauma bypass if there's significant trauma or you have a clinical concern for your patient. Another part of this list, though, is physiological. So when it comes to the physiological, you kind of have to go along with the patient presentation of what's going on with them. So with this one, for the physiological, it's patients who have any of the anatomical physiological indicators in Table A, along with physiological here, they may require services at HSC. So we have to keep in mind that this goes along with whatever their other condition is. So if someone's got a decreased GCS, it's not trauma related, we're not going to activate this. So they kind of play together. So with this, it's physiological and stable vital signs based on their actual trauma conditions, such as decreased LOC, hypotensive, and it says heart rate greater than 120 beats per minute. So we have to kind of keep in mind that someone that's suffered a lot of trauma is going to have an elevated heart rate. Actually, bradycardia is probably more of a concern if they just had a severe car accident, they're injured. So keep that in mind as well. But if they've got an excessively fast heart rate and it's deemed more so they're trying to compensate for low blood flow, hypotension, as opposed to they're just full of adrenaline because they just got in a car accident. So kind of again, do your assessment. These are considerations, and when in doubt, make a phone call to the trauma physician. So if they don't have anything listed in table A, like there's not really anything presenting as 100% severe right now, the vital signs are, they're going to be different, but they're acceptable for what we're dealing with. We're going to look at, is there any indicators for trauma bypass listed in table B? So table B tends to look more so at mechanism of injury. So again, they may not be presenting with a lot of concerns right now, but it doesn't mean that 20 minutes down the road, they're not going to start developing signs, symptoms, internal bleeding. That takes time for us to tell, right? We can't always tell right away. So things that can be really suspect is falls for adults greater than 10 feet, children greater than 2 times the height of a child. And the big thing we always have to consider with falls for kids too is that when they get younger, their heads are bigger, so they tend to plow their heads first. So we're always worried about head injuries. So that's a concern with the mechanism of injury. High energy auto collisions. So again, just if the car is wrecked, and in previous presentations I've done for trauma bypass, we talk about crumple zones in cars where the cars are designed to fall apart. So we have to keep that in mind that yes, the front end of the car may be destroyed, but they're designed to take that impact and take that energy. So, look at what's going on. It's more so the passenger compartment we're concerned about. T-bone injuries are probably the worst because there's limited protection for the passenger when they get those T-bone accidents, because front back they got crumple zones, you got the engine, you got the trunk, but on the side there's basically just a door. So those are probably going to be more the worst accidents you're going to find. So that's why it says for high energy auto collision intrusion any side of the vehicle greater than 18 inches, we're looking at the passenger compartment. Definitely if the tail end of the car is completely destroyed, that's concerning. There's a lot of force involved there, so we gotta kind of keep that in mind. Talks about vehicle telemetry data consistent with high risk of injuries. So again, this is if they have like OnStar or an onboard computer that activates 911 automatically because it detects that there's been a high impact. That's concerning because it was strong enough to actually activate automatic 911 dispatch. It's got auto versus pedestrian cyclist. So obviously, if a victim's been run over, that's not a good thing. That's kind of intense. Impact between vehicle and victim greater than 30 kilometers an hour. So pedestrian got hit by a moving vehicle, and that doesn't have to be like a car. It could be a quad, dirt bike, things like that. They're all going to cause their damage. It does say that motorcycle crash greater than 30 kilometers per hour without controlled slide. I'd say even with a controlled slide, there's probably going to be damage because a lot of people don't wear appropriate leathers, protective gear. And if they're just wearing their shorts and a t-shirt, and even if they do slide their bike and they're doing like 50K, they're still going to shred their limbs up pretty bad. So again, considerations, right? So even if there is a controlled slide, you're still going to do your assessment, make your phone call based on that. So other things to consider is special considerations. Honestly, the first one and the pregnancy, the patients with anticoagulants or bleeding disorders, that would also tie into A as well. But obviously with A, it's more severe injuries, illnesses, things like severe injuries, trauma. But we want to be concerned with patients with anticoagulants because obviously there's going to be a higher risk of them bleeding out and us not being able to control it. And pregnancy greater than 20 weeks gestation without apparent injury because pregnant patients take longer, especially vital signs, because moms can tolerate hypotensive a bit better than non-pregnant patients because their body will actually take blood away from the baby. So their blood pressure may be good right now, but that could be at the expense of the baby. So we want to make sure we're phoning those ones in. They should probably get assessed at HSC. And of course, significant injury in the same passenger compartment. So if they got T-boned, one person ended up in the lap of the other person, that's pretty bad. So there's some injuries there. So we want to make sure that we phone these in as well. So with that, if they don't have any of those considerations, we transfer the closest ED. So like I said before, we go to the closest ED. We can override bypass to get help if we think it's needed. But basically, the idea is that we go to the closest ED. They may have to get IFT'd out, which is very usually what ends up happening. But we just want to get them taken care of. It may not meet those requirements for bypass, so closest hospital could be appropriate. If the answer is yes, they do have considerations in Table B. We're going to contact trauma bypass before transporting, no matter where you are. So if they do have the criteria, like I said in Table B, you're an hour away, we're going to call MTCC and request trauma bypass. They're going to really need to know if you're within 30 minutes of the perimeter highway or not, because that's going to change who they activate on the dispatch side. So a patient with a high-risk mechanism of injury or meets special considerations as listed in Table B, they may require assessment by the Provincial Trauma Service, that's HSC eMERGE. So you may be directed to transport to a local ED for initial assessment based on the mechanism of injury. So again, it said pregnant patient with no apparent trauma right now. It might say, you know what, yep, absolutely, that's considerations, but go get them checked out at the local facility first, and then we'll IFT them out afterwards. The other thing we have to keep in mind as well is there's the triage component. So you may have multiple patients that meet the requirements in Table A or B, and HSC is just already maxed out. They've already had a couple car accidents. They've already got people from the city there. They've got people from other zones there. They may triage you until you go to closest facility first to stabilize them, look at possible IFT down the road. So just because we're enacting trauma bypass does not mean we'll always get sent directly to HSC based on what resources they have available. So just going back to Table A here. So if they do have indications for trauma as per Table A, so again, severe injuries, if the answer is yes, it's going to be important to know if you're within 30 minutes of perimeter highway when you call trauma bypass. And the reason for that is that if you're within 30 minutes of the perimeter highway, and this is new, they still want you to contact dispatch for trauma bypass while you're en route. So again, with trauma patients, we don't want to sit around on scene any longer than we need to be, especially if it's really bad and it's really hard to maintain. So if you're within 30 minutes of the perimeter highway, just start heading to HSC and make a phone call while you're en route. So if you are within 30 minutes, dispatch will connect you to the vectors physician. This is new. They will connect you to the vectors physician only so patient-specific information can be obtained and the trauma team can be alerted at HSC to be ready for your arrival at hospital. So with the new trauma bypass, MTCC will put you in contact with the vectors physician, not the STARS physician for this. But they will, so what that does is the vector physician has ability to do a triage. So they're going to ask you some basic questions. It's not going to be a huge report, but they'll get a report from you, and they will actually page out the trauma team and have them ready to go. So when you get to HSC, that they're all ready and they've had a bit of a briefing, so they're ready to go when you arrive, so they won't have that pause at triage. If you're going to HSC, if you're going to HSC adult ED, it's for 17 years and older for all traumas. You're going to go to the adult side. For penetrating traumas, ages 12 to 17, you're going to go to HSC adult side. This is just because they have more resources, they have more training. Well, I don't want to say more training, but they have more experience with this. They have more resources to deal with these kind of traumas. So stabs, shots, things like that. They just see it more on the adult side and they're more prepared for it. So with that as well, so if you're going to go to HSC adults and you've got like a 13-year-old that was stabbed, make sure when you radio in, you're giving your CTAS. So you're coming in CTAS 2, penetrating trauma, 12-year-old. Make sure you mention that it's penetrating trauma as per bypass. That way they don't question over the radio, why are you coming here? Go to children's. So just make sure you relay that over the radio. For the children's side, 12 to 17, we're just going to take the blunt traumas to that. So if they got hit by a car, that's going to go to children's. If they got stabbed, they go to adults. So for 12 to 17, blunt trauma goes to children's. And under 12, no matter what the trauma is, they go to the children's side. But again, we're still going to contact the vector's physicians. They can activate the trauma team and get them rolling before we get there. Especially on the children's side, the more heads up, the better. So if you're not within 30 minutes, if you're greater than 30 minutes from the perimeter highway, dispatch will conference you with both the STARS transfer physician and the vectors physician. So you'll be talking to multiple physicians at the same time. And again, this is new with adding vectors. So when you call dispatch saying you're more than 30 minutes away, MTC, it's all on MTC side. We don't have to request specific physicians anymore. They will make that decision and they will notify the correct people. So with that, if transport to the perimeter is greater than 2 hours or 120 minutes, head towards the closest ED, or you may be directed to a specific non-trauma facility. So if they say, well, is there a hospital open further south? How far away is it? Go there first versus the close facility. They may redirect you to the most appropriate facility, not necessarily HSC or not necessarily the closest one. They might tell you to go somewhere further south or closer to the city. If you are within 120 minutes or 2 hours from the perimeter, you may be directed to a landing site for helicopter intercept. So again, this is why STARS transport is involved with the vector's physician, because if STARS is already on a call, we're not going to consider that intercept, whereas STARS might have been auto-launched already, and they can help coordinate where you're going to meet with the helicopter if you can't sit on scene because your patient is critical and you don't want to sit there for 20, 30 minutes waiting for the helicopter to get to you. They might land the helicopter and you can go meet them. Again, this is all done on the dispatch side. For us, it's just phoning in saying we're requesting trauma bypass. I'm within 2 hours of Winnipeg, and then dispatch will put you in contact with both vectors and the STARS physician. And with that, so we call in, we ask for trauma bypass as soon as possible. Again, patient care comes first. We want to make phone calls as soon as we can, though. And based on where we are, what resources available, we're going to continue transporting or redirect as advised. So if that means they're like, you know what, just keep going straight to HSC Children's, then we do that. And that is the trauma bypass updates. So with that, again, not too much difference in what we're already doing. The big thing is just who we're going to be talking to. So again, as of June 1st, we're going to be contacting dispatch requesting trauma bypass, and based on destination and distance, they're either going to put us in control with just contact with just the vector's physician or with the vector's physician and the STARS transport physician. Again, that's all on MTCC side. We just have to make sure we're aware of how far away we are from facilities and make sure that we're calling and requesting trauma bypass, not just can I talk to the STARS physician, things like that. Thank you very much.